our keynote address by Dr. Neil Blumberg. Dr. Neil Blumberg is the director of the Transfusion Medicine Division and Blood Bank of an 880-bed university hospital and professor of pathology and laboratory medicine at University of Rochester, New York, USA. He received his BS and MD from Yale University in New Haven City and had his residency training in laboratory medicine, hematology, blood banking at Yale New Haven Hospital. Dr. Blumberg's particular interest is in transfusion immunology, having participated in research into the previously unappreciated immunological effects known as transfusion immunomodulation. His clinical interests are in the diagnosis and treatment of immune disorders, such as autoimmune hemolytic anemia, autoimmune thrombocytopenia, supportive care for stem cell and solid organ transplantation, and mitigating transfusion side effects through leukoreduction, use of autologous transfusions, and the removal of stored supernatant through washing. His group, co-led by Dr. Joanna M. Hill, MRCP, described the ill effects of transfusing ABO incompatible solution antigen antibody. Dr. Blumberg is a member of several professional societies, including Bloodless Medicine Surgery Society and the Society for the Advancement of Patient Blood Management. And he is in the Hall of Fame of the Association for the Advancement of Blood Biotherapies. May I call upon Dr. Neil Blumberg, please?
Thank you so much, Chris. See if I can share the appropriate screen here. Can everybody see the slides? Okay, so one thing I should say is I am not an active medical or surgical oncologist or palliative care physician. I'm a hematologist and clinical pathologist, and my primary responsibility, obviously, is for transfusion medicine, a very small part of the care of patients with cancer or any other disorder. But unfortunately, transfusion has sort of become embedded in the clinical practice of many oncologists, surgical or medical, over the decades, so that they looked at it very casually. And there are for those who take care of patients, for example, with acute leukemia, it's clear that there are some patients who are very hard to manage, if not impossible, without using transfusion. But what we're trying to address over the last 30 or 40 years is that we need to move to a bloodless model when that's possible, and certainly to reduce the use of transfusions when absolutely essential to an absolute minimum. And I'm going to try to discuss some of the scientific and clinical background to that. Starting about 40 plus years ago, it became clear that patients with solid tumors in particular, any type of cancer that was a solid tumor, who was transfused during the early part of the therapy, usually involving surgery or radiation therapy, that these patients did much worse in terms of disease recurrence. And in fact, we have not had randomized trials except for one or two that I will show you that answer the question, is this a cause and effect? Because it's very hard to determine cause and effect just from observational studies. But some of the risk ratios are in the 4, 5, 6-fold increase in recurrence, which are very unlikely to be explained by mere association or confounding. I will show you data from leukemia patients where we've been able to intervene and change the prognosis that suggests that transfusion is in fact causally involved in increased tumor recurrence, at least in the liquid tumors like the acute leukemias. But most of this talk is going to focus on things that happen to patients when they are transfused that are unfavorable other than tumor recurrence. So I'm going to start actually at the end of the story, which is that we know that transfusions have profound effects on immune function. And as you can see from this summary that was published 30 years ago, it's a very, very long laundry list of immune modulation. The immune modulation is not well accepted in the field of transfusion medicine, and perhaps not in hematology, but it's very real. And this has been demonstrated in animal models and in patients. And none of these things are favorable if you have cancer. I'm not going to go down through the list. You can read it at your leisure or in the original paper. But they all involve decreases in cellular immune function, upregulation of, in general, humoral immunity, decreased cytotoxic function. And now we have modern therapies like CAR T cells, chimeric antigen receptor T cells, which are autologous gene-modified therapy many of you are familiar with in lymphoma, particularly in multiple myeloma and acute B-cell leukemia. What we have seen is that the patients who require transfusions after CAR T-cell therapy have much higher rate of cancer recurrence. So transfusion in this setting is a problem as well, even though I think immunotherapies are, in fact, the future of cancer therapy. It's hardly an original idea on my part. So this is a schema that was published some years ago in Transfusion, and it's meant to emphasize the fact that transfusions are the worst of both worlds. They not only impair cellular immunity, which impacts things such as cancer recurrence, but they also cause inflammation. Transfusions of red cells and platelets are pro-inflammatory. They impair the ability to clear infections, which are very common, obviously, in cancer patients. They impair wound healing after surgery, and in general contribute to organ dysfunction. And one of the schemas shows that, in fact, type 1 responses, cellular immunity, are inhibited by transfusion, and type 2 responses, which are antibody responses, are in fact promoted. And antibody responses don't really help much in cancer, as it turns out, where cellular immunity is very important. And in this animal model, the late Wesley Alexander and his group showed that type 2 cytokines like IL-4 and IL-10 are in fact increased and IL-2 decreased after transfusion in animal models. So there are a number of these type 1 responses that are antagonized, and then for example, they will inhibit allograft rejection. Kidney patients who've had a kidney allograft will have better organ survival if they're transfused. We can also treat the rejection of fetus as an allograft, and some inflammatory diseases may actually benefit from transfusion. But in fact, antibacterial immunity, anti-tumor immunity, antiviral immunity are all impaired by transfusions. So to give you an idea of how this works in patients, this is a randomized trial done by Jill Trillette in our institution, published some years ago, in which we looked at wash transfusions with the hypothesis that the stored supernatant plays a major role. And I'll show you some data from leukemia later. But in this pediatric cardiac surgery population, which obviously is not cancer, what we found was that wash transfusions mitigated some of the inflammatory response. IL-6 levels post-operatively in the wash transfusions groups were considerably less so than in the unwashed group. So this shows in a randomized trial that the inflammation of transfusion can be mitigated in part by, in fact, washing, which is a very unpopular approach in the United States. In fact, there's an enormous prejudice against the idea of washing, but it has the potential to make transfusions, when necessary, considerably less harmful. In terms of cancer after transfusion, there are some data from epidemiologic studies that, in fact, blood transfusions may, in fact, lead to long-term immune changes and other changes that have led to an increase in cancer. So this is a United Kingdom study of women who received transfusions for non-cancer diagnoses. And then after 8 years, for example, the rate of liver cancer was about threefold higher. The rate of non-Hodgkin's lymphoma was about twofold higher. So we don't know what this is, whether it's immune modulation or unknown viruses or in the transfused blood, but transfusion may be associated with long-term risk of increased cancer. And this is some of the other data from that study. And it looks like, in fact, that patients who had surgery for colon cancer, for example, had a fourfold increase of recurrence. And if you look at non-Hodgkin's lymphoma, a fivefold risk of recurrence, and in leukemia, a sevenfold increase. So there are some tumors that don't seem to be affected, thankfully, such as breast cancer. But in fact, transfusions are at least epidemiologically associated with increases in recurrence rate in cancer patients who undergo surgical or other interventions. And perhaps the most convincing data from Marcus Heiss in Germany, from almost 30 years ago, published in the Journal of Clinical Oncology, is he randomized patients to receive autologous transfusions, which we now know from many years of work are not as immunomodulatory and may actually be immunostimulatory. And in fact, the patients who were randomized to autologous blood had considerably better recurrence rates. And this is tumor-free survival in patients who only got a few units of blood, less than 2 units of blood. And as you can see, the autologous group, albeit a small study, did statistically significantly better than the allogeneic group, which adds to the data that allogeneic transfusion in cancer is a double-edged sword. It may relieve symptoms, it may prevent certain problems, but on balance, it's really not good for cancer patients. It's bad for cancer patients. And when you give, for example, platelet transfusions, this is a study done a number of years ago in our institution, patients getting prophylactic pre-procedure platelet transfusions had a very high rate of mortality over the succeeding 30 days. Obviously, some of this is because they were very sick, but some of it may be because of the immunomodulatory effects of platelet transfusion, and the patients who died of inflammation and septic shock by and large. So one of the very important problems that oncologists have been dealing with now for some time is cancer-associated thrombosis. And this was actually brought to the attention of the medical community, mostly through the work of Ala Khurana, who was a colleague here in Rochester for a number of years. He's now at the Cleveland Clinic and has been one of the world's leaders in studying the issue of thrombosis in cancer patients because it's a common problem. Thrombosis is associated with inflammation and with cancer, and obviously autoimmune diseases. And in fact, there are obviously patients who are on aspirin or anticoagulants have a lower rate. So the question is, what is the problem in cancer patients? And this is a model that I've stolen from a Canadian presentation on the subject, but patients with various cancers do seem to be at increased risk during their treatment of thrombosis. And this is primarily deep vein thrombosis and pulmonary embolus rather than arterial thrombosis, but arterial thrombosis is probably also increased. So what is cancer-associated thrombosis? Obviously, a patient with cancer who develops a venous thromboembolism, and it's actually quite a striking increase, 4 to 7-fold. It can occur early on, it can occur late, but it's most frequently diagnosed in the first few months after cancer. And this is a common complication obviously, and we do have some treatments, and we're just beginning to, when I say we, I mean oncologists who are interested in this subject, rather than myself personally, explore which patients should be anticoagulated. And I'm sure you're all familiar with the different types of thrombosis, particularly deep vein thrombosis in the legs and the pulmonary emboli. It's rarer in the arms, but with catheters in place, that can increase the risk. So it turns out, and Ala Corona and many other colleagues throughout the world have shown that this is actually a very common cause of death in patients with cancer, second only to direct cancer-related deaths themselves. It's the second leading cause. And that patients who develop a venous thromboembolism have higher mortality overall. And it can certainly become problematic for continuing treatment of the primary tumor. So about 1 to 12% of patients develop a thromboembolism, but cancer, it varies from disease to disease. And in fact, fatal pulmonary embolism is the leading cause of sudden death among hospitalized patients, and this includes cancer patients. And the same things is true of cancer patients. And so with this graphic shows that much of this is undiagnosed until after death or at the end of life. And this is just some graphs showing the actual probability of death in patients with no hospitalized patients, no cancer and no thromboembolism, cancer alone. And when you add thromboembolism to patients who have cancer, the probability of death really goes up quite dramatically. This slide just demonstrates that the rate of thromboembolism seems to be increasing, probably because we're successfully treating cancer patients, keeping them alive for longer periods of time, and so they're at risk for longer periods of time. And obviously, most of these events in surgical patients, whether they're cancer patients or not, tends to occur fairly early after surgery, which is the major risk factor, but can be quite delayed. So the balance between bleeding and thrombosis is something familiar to all of you. We like to keep patients in this range where they're hemostatically functioning, they're not bleeding, they're not thrombosing. Turns out that the ABO blood group may play a role in this. Patients who are type A and type AB have higher rates of thrombosis. Type O have lower rates of thrombosis. Conversely, patients who are type A, B, and AB have lower rates of bleeding, and patients who are type O have higher rates of bleeding. But it turns out that what your blood bank is doing may greatly affect these things. Unfortunately, dogma has arisen in blood transfusion that ABO blue blood group, which is important for red cells in transplantation, does not matter for platelet transfusion. And unfortunately, this is total nonsense. There are randomized trials showing otherwise. It's very difficult to give ABO match platelets to patients because we can only store them for 5 to 7 days. And in fact, Laura Cooling did a study some years ago showed that 40% of platelet transfusions in her institution were in fact ABO non-identical. So the problem is that ABO mismatched transfusions are associated with platelet refractoriness, increased bleeding, multi-organ failure, and increased mortality in observational studies, and that, in fact, they make things worse in cancer patients. They also cause a wide range of relatively minor reactions, which are only minor to the blood bank director, not minor to the patient. And in fact, in randomized trials, Robert Carr in England many, many years ago, 34 years ago, showed that platelet refractoriness was about 10-fold higher in this small study of platelet transfusions in patients with hematologic malignancies. They made more HLA antibodies. They made more antiplatelet antibodies. And this is just data from our own group showing that patients who receive ABO and non-identical transfusions, which we no longer give to patients and haven't since about 1992 for hematologic patients and since 2005 for everybody, that bleeding is much more severe in recipients of ABO non-identical transfusions. And in fact, it does appear that the prevalence of major bleeding episodes is only about 5% in hematologic malignancy patients who get ABO identical, but that in the literature, 15 to 20% of patients bleed. And in the Plato study, a randomized trial done some years ago, they had a 70% bleeding rate, so almost 12 times higher than if you give ABO identical platelets. So we know from in vitro modeling that platelet dysfunction and generation of thrombin is impaired by anti-A platelet antigen interactions. Clot formation is not normal. And now we have some data from Columbia that's been provided in abstract form at this year's ASH, showing American Society of Hematology that in fact that ABO immune complexes from transfusion can cause vascular injury that leads to bleeding in the head. So we've shown in randomized trial that when we give ABO identical, leukoreduced, and wash transfusions, we have substantially better survival in our patients. So we can mitigate this. We can't make this effect go away on survival. And this is the randomized trial data showing that washed transfusions are significantly better than unwashed in younger patients with acute myeloid leukemia. And this is comparing our data in these younger patients with the New York State data, which from the cancer registry. As you see, we have a 20% mortality rate at 5 years versus 50%. This is not a randomized trial, obviously, but these are really striking differences in clinical outcomes. So we know that transfusions are, in fact, associated with infection. They're associated with thrombosis and cancer recurrence. These are not good things. And so in cancer, we believe that it's really quite important to try to minimize transfusions or use, if possible, bloodless medicine techniques, because transfusions are really predisposed to a wide variety of bad outcomes, including mortality, that using restrictive transfusions or autologous transfusions can reduce this effect but not make it go away, that we can use leukoreduction and washing to reduce some of these side effects. But once again, mitigation is not the same as abrogation. So if we can avoid transfusion, that is by far the best outcome for these patients. And if we have to use transfusions, we should use them very conservatively, and they should be leukoreduced and ABO identical. I'm going to finish this talk just by acknowledging some of my collaborators over the years. My most important collaborator is Dr. Joanna M, who co-led our research group. Joanna and I have also shared a couple of mortgages and a couple of children and one grandchild. So it's been a very important part of this research, and I don't want to pretend that I was the key person by any means. Some oncologists and hematologists, Dr. Rowe, now in Israel, Dr. Liesfeld at our institution, Gordon Phillips, who was head of our stem cell transplant program, and Ala Khorana's mentor, Dr. Charlie Francis, one of the world's experts on hemostasis thrombosis. Folks in the blood bank, Dr. Majid Rafai, who you'll hear from tomorrow, and is on the panel, our chief supervisor, Debbie Maisel, and one of our technical staff, Kelly Hendricks, and a wide variety of other clinicians and basic scientists. And very grateful for the opportunity to address this group. And I will stop my screen sharing now.